Hello everyone, my name is Dr. Ambit Misra, and in this video we are going to discuss about sphingolipidosis, that is your lipid storage disorders. As you can remember, in the previous video we discussed about the enzymes and the substrates that are involved in these diseases. So for better understanding of these diseases, I would recommend you to please go and watch that video that is on your phospholipids and glycolipids, the substrates and the enzymes that are involved. So in this video, starting with this sphingolipidosis, that is your lipid storage disorders, which is a form of a lysosomal storage disorder, and also a type of inborn error of metabolism, and these are inherited, and most of them are autosomal recessive, except your Fabry's disease, which is your X-linked recessive. Except Fabry's, all are autosomal recessive, and the Fabry's is your X-linked recessive. Now, the deficiency of certain enzymes is going to lead to accumulation of the corresponding substrate that the enzyme is responsible for breaking down. So these substrates are going to get accumulated, and these substrates are nothing but the complex lipids, which are in normal condition is being broken down by these enzymes, which when got defective leads to accumulation of these lipids. And these lipids are nothing but your sphingolipids, and sphingolipids are the lipids which contains sphingosine as a backbone. So in the previous discussion, we saw all these lipids which contain sphingosine, that is your sphingomyelin, all the glycolipids, that is your cerebroside, globoside, ganglioside, all these contains sphingosine. So sphingolipidosis means accumulation of those lipids which contains sphingosine, and all those lipids are your sphingomyelin, your all these glycolipids, that is your glucose, that is your cerebroside, globoside, and your gangliosides. So in the previous video, we also saw that the substrates and the enzyme that is responsible for breaking down that particular substrate. So again, we will discuss this so that it remains in our fresh memories. So GM1 ganglioside is being broken down by beta galactosidase. So we need to remember galactosidase, GM1 gangliosides, which is form GM2 ganglioside from GM1 gangliosides. And the GM2 gangliosides are broken down by beta hexosaminidase, which has two isoforms A and B. So hexosaminidase A has two subunits, one alpha and one beta, and beta hexosaminidase B has two subunits, that is your two beta subunits. Again, we have your cerebrosides that are of two types, glucocerebrosides and your galactocerebrosides. So glucocerebrosides are being broken down by beta glucosidase. So gluco goes with gluco, and which is going to form ceramide plus glucose. And your galactocerebrosides, that is the enzyme that is responsible for breaking galactocerebroside, is your beta galactosidase. So here again, galacto goes with galacto. So glucocerebroside and galactocerebroside, the enzymes is really easy to remember, because they here the gluco goes with gluco and galacto goes with galacto. Next, moving on to your sphingomyelin. Sphingomyelin is being broken down to ceramide and phosphorylcholine. Again, it is really easy to remember, because sphingo for breakdown of sphingomyelin, the enzyme responsible is your sphingomyelinase. So sphingomyelin goes with sphingomyelinase. And again, ceramide is broken down into sphingosine and free fatty acid, and the enzyme is your ceramidase. So this is also not a problem. Next is a type of globoside, that is your GL3, which is being broken down to ceramide and triglycoside, and the enzyme responsible is your alpha galactoside. alpha galactosidase. So here we need to remember alpha and we need to remember galacto. So here it is your alpha galactosidase. So overall, the four substrates that you don't need to remember the enzymes. You see, the glucocerebroside, the galactocerebroside, sphingomyelin, and ceramide, because the name of the enzyme is similar. So these four, you can easily remember the name of the enzyme and name of the substrate, because the both these go like both have, they sound similar and they have similar name, and the name of enzyme goes perfectly along with the name of substrate. What you need to actually remember is your GM1 GM2 gangliosides. So see, GM1, that's how you can remember for GM1 GM2. So the alphabet G comes first and H comes later. So by first, you can remember first is your G, because G comes first and then comes H after G. So 2 is your H. That's how you can remember. So GM1 is your beta galactosidase and GM2 is your beta hexosaminidase. Only one place where you are going to see alpha is your globoside. So like whichever is like very different, see, that is your globoside, that where you will see alpha galactosidase. So that's how I remember, and that's how you can remember. If you have any another tricks to remember, that's also good, you can remember by that. So now by keeping these substrates and enzymes in mind, we will discuss different types of sphingolipidoses. We saw like what is this lipidosis. Now going into the diseases particular, the first one that we are going to discuss is your Neimann-Pick disease. The enzyme defective here is your sphingomyelinase, and the substrate that is going to get accumulated is your sphingomyelin. That's obvious by the name. And this sphingomyelin is going to get accumulated in liver and spleen, which in turn is going to lead to hepatosplenomegaly. Now, what are the other clinical features that we need to remember is your mental retardation. Next one, that in Neimann-Pick disease, the death may occur, in very early stages of the life, in very early childhood. So death may occur in early childhood. The next one is your cherry red spots on macula. Cherry red spot on macula. So this cherry red spot, you can see this bright cherry colored spot that you are going to see over the macula. So this is a really important feature for Neimann-Pick disease. The next feature that you are going to see is your zebra body inclusion. You are going to see ataxia and speech difficulty. Ataxia means a lack of voluntary coordination while doing the movement. So the important things that you need to remember here is your hepatosplenomegaly, cherry red spot on macula, death in early childhood, like it is also important, like you are not going to see in many other sphingolipidoses, and your zebra body inclusion. So these you must remember. Moving on to the next, your Fabry's disease, the enzyme defective is your ceramidase. And if ceramidase is defective, there will be the accumulation of substrate, that is your ceramide. Ceramide is going to get accumulated. What is the clinical feature? The clinical feature is The clinical feature is painful joint swelling, painful joint swelling that is going to cause deformation of joints. So there you can see over the knuckles of this baby, you can see the swelling, that is your joint cell swelling, and because of that the joints are going to get deformed. Next one is your Gaucher's disease. There is the defect in the enzyme beta glucosidase. Beta glucosidase. So there will be accumulation of glucocerebrosides, that too in extraneural tissue. Extraneural tissue. You see, glucocerebrosides are present in extraneural tissue and galactocerebrosides are present in neural tissue. So the beta glucosidase, which is the enzyme responsible for breaking down glucocerebrosidase, which is present in extraneural tissue. So in this case, you are not going to see mental retardation. Why? Because glucocerebrosides are not found in neural tissues. It is found in extraneural or non-neural tissues. So your Gaucher's disease is your most common lysosomal storage disorder. This you need to remember that it is the most common LSD, and the glucocerebrosides are going to accumulate in extraneural tissues. So what are the clinical features that we are going to see? That is your pain in long bones, that are going to cause pathological fracture due to osteoporosis. Next, we will be seeing decreased thrombocytes and pancytopenia. Because of decreased thrombocytes, we are going to see bleeding manifestations. And because of pancytopenia, we are going to see anemia. Next is that we are not going to see mental retardation, and we are not going to see cherry red spots. Both are these we are not going to see in case of Gaucher's disease. Instead, you are going to see hepatosplenomegaly. The hepatosplenomegaly will be present, but mental retardation and cherry red spot you are not going to see in case of Gaucher's disease. Now on X-ray, you are going to see Erlenmeyer flask deformity. What is Erlenmeyer flask deformity? It's this one. You see, the bones here are like this, and here you can see the bones are a bit eroded. So what is Erlenmeyer flask? You must have seen in your labs something like this kind of flask. So the end of your bone is going to appear like an Erlenmeyer flask. So Erlenmeyer flask deformity is what you are going to see on X-rays in case of Gaucher's disease. So Erlenmeyer flask deformity. The next clinical feature that you are going to see is in your bone marrow on on in during the histopathological examination, you are going to see Gaucher cells. Gaucher cells, where you are going to see crumpled tissue paper, crumpled tissue paper appearance, crumpled tissue paper appearance. If you can appreciate this here, this that you are going to see is a crumpled tissue paper appearance when you will, do the histopathological examination of bone marrow. Another one is your Erlenmeyer flask deformity. You are not going to see mental retardation and no cherry red spot, but you are going to see hepatosplenomegaly. Now, these are the things about, most important and most common lysosomal storage disorder, and most important is sphingolipidosis, that is your Gaucher's disease. So the Erlenmeyer flask deformity, that you need to remember, crumpled tissue paper appearance, or Gaucher cells. These are also known as Gaucher cells, that you need to remember. But you are not going to see mental retardation or cherry red spot. See, if you remember the substrates, the location where these substrates are present, you can easily figure out if the patient will have mental retardation or not. So like in the previous discussion, we discussed about the location of these lipids, the exact location where these are found. If these lipids are not found in neural tissues, these are primarily found in extraneural tissues, you are not going to see mental retardation. And if these are present in neural tissues, you are definitely going to see some kind of deformity, some kind of defect involving your neural tissues. The next one is your Krabbe's disease. In Krabbe's, the defect that you are going to see is your beta galactosidase, and there will be accumulation of cerebrosides that you are going to see in neural tissues, because your galactocerebrosides are present primarily in your neural tissues. So the accumulation of galactocerebrosides are seen when the enzyme defective is your beta galactosidase, that is your Krabbe's disease. And what are clinical features that you are going to see in this case is your severe neurological deficit. Severe neurological deficit that is due to absence of myelin formation. Absence of myelin sheath formation. The myelin sheath won't be formed at all, so that's why you are going to see severe neurological deficit in case of Krabbe's disease, because the substrate responsible here is your galactocerebrosides, which is mainly found in neural tissues. You are also going to see cherry red spot you are going to see, and you are going to see globoid inclusion, that is your enlarged macrophages. Here, that too you are going to see in white matter of brain, white matter, but you are not going to see hepatosplenomegaly. Hepatosplenomegaly is not seen in case of Krabbe's disease. So there is one more way that you can remember these diseases is by making a pair. So you see, first and second, that is your Neimann-Pick and your Farber. So Neimann-Pick, the deficiency is your sphingomyelinase, because sphingomyelin is going to get broken down into ceramide, and then ceramide is being broken down into sphingosine and fatty acid. For the first one, when the sphingomyelin is being broken down to ceramide, the enzyme responsible is your sphingomyelinase. So sphingo goes with sphingo. And the next one is your Farber's disease, where when ceramide is broken down into sphingosine and fatty acid, and the enzyme responsible is your ceramidase. So you can combine Neimann-Pick with Farber's, and you can combine Gaucher with Krabbe's, because in case of Gaucher, both these are because of the accumulation of cerebrocytes. One is glucocerebroside, one is galactocerebroside. Glucocerebroside is found in extraneural tissue, and galactocerebroside is found in neural tissue. Because glucocerebroside is found in extraneural tissue, so you are not going to see mental retardation, but you are going to see but you are going to see hepatosplenomegaly. But Krabbe's disease, in case of Krabbe's disease, galactocerebrosides are involved, which is present in neural tissues. So you are going to see severe neurological deficit, but no hepatosplenomegaly. So please, when you remember this, combine Gaucher with Krabbe and combine Neimann-Pick with Farber. That's how you can easily remember. Now, you are not going to see hepatosplenomegaly, but you are going to see severe neurological deficit. And one important differentiating feature is your globoid inclusion. So please remember those differentiating feature that you are not going to see elsewhere. So in this case, this is your globoid inclusion, that is your enlarged macrophages. See this one right here, this one, this one, this one, and this one. These are your globoid inclusion. So here in this case, globoid inclusion. In case of Gaucher, please remember Erlenmeyer flask and crumpled tissue paper appearance. And in case of Neimann-Pick, please remember zebra body inclusions. So please remember these differentiating features, that is really going to help you differentiate a particular disease, particular sphingolipidosis from other. Now next one is your Tay-Sachs disease. Now Tay-Sachs, there the defect in the enzyme is your beta hexosaminidase, and the accumulation of GM2 gangliosides are seen. So you see, the GM2 gangliosides, the enzyme responsible is your beta hexosaminidase, which will break down GM1 into GM2 into GM3, and beta galactosidase, which will break down GM1 into GM2. So which substrate is going to get accumulated in case of Tay-Sachs is your GM2 gangliosides. So T for 2, you can remember this, and for 2 we remember 1 is G and 2 is your H, because G comes first. So that's how in case of G, that the GM1 ganglioside is going to get accumulated, and G is your galactosidase. And in case of H, that is your hexaminidase, GM2 ganglioside is going to get accumulated. And see, these are also known as GM2 gangliosidosis, because in this case, the gangliosides that are going to get accumulated is your GM2, that is your Tay-Sachs and Sandoff. So Tay-Sachs we are discussing first. So defect is your beta hexosaminidase. The accumulation of GM2 gangliosides are going to be seen. The clinical features are blindness, and you are also going to see cherry red spot in macula and retina. The next one, you are going to see mental retardation. You are going to see macrocephaly, big head, and death within 2 to 3 years of age. Next one is your hyperacusis. You are going to see hyperacusis. That is your increased sensitivity to the sound. Increased sensitivity to sound. Like the patient cannot tolerate even normal sound. That normal sound is going to appear as very loud sound. That is your hyperacusis. So these are the features of your Tay-Sachs disease. From Tay, you can remember GM2, and again, the defining feature, that is your hyperacusis, and death within 2 to 3 years. But remember, hyperacusis is very important feature, and blindness along with choroid spot is also the defining feature. Moving on to the next, that is your Sandoff. The enzyme defective is your beta. Sorry, in case of Tay-Sachs, the enzyme defective is your beta hexosaminidase A. All right, and in case of Sandoff, it is your beta hexosaminidase A and B both. We saw here that hexosaminidase has two isoforms, A and B. A has two subunits, 1 alpha and 1 beta, and B has two subunits, that is your 2 beta. So in case of your Tay-Sachs, only hexaminidase A subunit is A isoform is defective, while in case of Sandoff, A and B both are defective. So now in case of Sandoff, it is beta hexaminidase A and B both are defective. Again, there will be accumulation of GM2 gangliosides. Because beta hexaminidase A is responsible for breakdown of only GM2 gangliosides into GM3. So that's why these are called GM2 gangliosidosis. So the example of GM2 gangliosidosis are your Tay-Sachs and Sandoff. In Tay-Sachs, the enzyme enzyme deficiency is your beta hexaminidase A, and in case of Sandoff, the enzyme in deficit is your beta hexaminidase A and B both isoforms. In both these cases, there will be accumulation of GM2 gangliosides, and in this case, in case of Sandoff, you are going to see all the features of Tay-Sachs, plus you are also going to see hepatosplenomegaly, cardiac abnormality, and some bony deformities. In case of Sandoff, you are going to see all the feature of Tay-Sachs, that is your blindness, mental retardation, macrocephaly, and hyperacusis. Plus also you are going to see hepatosplenomegaly, cardiac abnormality, and bony deformity. So I told you, like, you can remember by pairing two diseases. So here you can pair Tay-Sachs and Sandoff, that is your GM2 gangliosidosis. In both these cases, there will be accumulation of GM2 gangliosides, but the enzyme that is defective in Tay-Sachs, it is your hexaminidase A, and in case of Sandoff, it is your hexaminidase A and B both. Here it is only A, here it is A and B both. Moving on to GM1 gangliosidosis, the enzyme defective is your beta galactosidase, and there will be accumulation of GM1 gangliosides, because Beta galactosidase is responsible for breakdown of GM1 ganglioside into GM2 gangliosides. That's why there will be accumulation of GM1 gangliosides. Now, what are the clinical features that you need to remember? Is your blindness. You will see frontal bossing, frontal bossing, long philtrum, these are the facial features, depressed nasal bridge, low set ears, angiokeratoma, hepatosplenomegaly, mental retardation, and macular cherry red spot is going to seen in 50% of the individuals. Now, angiokeratoma. This is how angiokeratoma looks like. It looks like, blackish, brownish, pigments, like pointed pigments that you are going to see is spread on the different parts of the body. And the facial features that you are going to see this here is your long philtrum. You see depressed nasal bridge, and low set ears. These are the clinical features that you are going to see. And you need to remember angiokeratoma. And this is the only disease, like only sphingolipidosis, like that is your GM1 gangliosides. Whenever in the question you see, facial features, like telling something about the facial feature, like low set ears or depressed nasal bridge or long philtrum, immediately you can jump onto the conclusion that it is your GM1 gangliosidosis, and the enzyme defective is your beta galactosidase. So this is how angiokeratoma looks like, and these are the facial feature in case of GM1 gangliosidosis. The next one is your Fabry's disease. In Fabry's disease, the enzyme defective is your alpha galactosidase. This is your X-linked recessive that I told you earlier. This is the only disease which is X-linked recessive. Rest all of them are autosomal recessive. There is accumulation of globoside, that is your globotriaosyl ceramide. This is a type of globoside which is going to get accumulated in case of Fabry's disease. Now, what are the clinical features that we need to remember here is we are also going to see angiokeratoma, corneal and lenticular opacities. You are going to see opacities in the cornea and also in the lens, and also you are going to see angiokeratoma. You are going to see Fabry's crisis. What is Fabry's crisis? That is pain in proximal joints. Another feature is your hypohidrosis. That is your decreased sweating. And in urinary sediment, you are going to see these Maltese cross appearance, and this is due to lipid inclusions that you are going to see in the urine. So Maltese appearance in urine. So this is your Maltese appearance. You see, this is forming, a cross kind of thing. So this is your Maltese cross appearance that you are going to see in urinary sediment in case of Fabry's disease. Hypohidrosis is an important feature, and nowhere you are going to see corneal and lenticular opacities. This is you are going to see only in case of Fabry's disease. So remember, whenever you are going to see like opacity in the lens or in cornea, along with decreased sweating, and in urinary sediments, if it's mentioned that patient is having Maltese appearance in urine sediment, like immediately you can jump onto this Fabry's disease. Now these are the different types of sphingolipidosis. We can discuss some general features of sphingolipidosis. All are autosomal recessive except Fabry's, that is your X-linked recessive, that we have already seen. Now all these sphingolipidosis has mental retardation as a clinical feature except your Gaucher. In Gaucher, you are not going to see mental retardation. This is really important. If all these features are given and it is a lipid storage disorder, but it is not, including mental retardation as a clinical feature, this is your Gaucher's disease. All have cherry red spots on macula except your Gaucher and your Fabry. So your GF don't have cherry red spot on her macula. Now sphingolipidosis with corneal clouding that you are going to see in case of Fabry's and GM1 ganglioside. Sorry, you are also going to see this corneal clouding in Fabry's and also in GM1 ganglioside, but not lenticular opacities. Lenticular opacities you are only going to see in case of Fabry's. So these are the general features. That's how you can differentiate these sphingolipidosis. One more important thing that is very helpful in differentiating these different sphingolipidosis is your inclusion bodies that you are going to see. So the globoid you are going to see in case of Krabbe's. Zebra is you are going to see in Neimann, and Maltese cross is going to be seen in Fabry's. So this was all about sphingolipidosis. Please make your own tricks. If you find it hard, please do one thing. You just need to make pair of these diseases. Make pair of first and second and third and fourth and fifth and sixth and seventh and eighth that I told you. By making pair, you can easily differentiate two diseases, and in questions mostly they are going to confuse those diseases with similar features, only few differentiating features. So that's how you can remember these in pairs, and that will be really easy for you to remember all these. And also please remember these enzymes and the corresponding substrate, and that's really easy because here these four are really easy to remember because the name of enzyme goes along with the name of your substrate, sounding similar. And in case of GM1 and GM2, you can remember by G comes first, so it's GM1, the substrate is GM1. H comes later after G, so it's second, so that is your GM2 as a substrate. And in case of, and the rest that is left is your globoside, that is your alpha galactosidase. So this was all about sphingolipidosis. I hope you liked this discussion. Please do share these videos with your friends and your juniors, and please drop your suggestion in comment box, like which topic that you want me to make a separate video on. And thank you for listening to this discussion. Have a nice day.